So I just wanted to talk to you for just a few minutes today about the power of knowledge and the empowering presence in communities and how important that is to empower communities to be more knowledgeable about breast cancer and disparities and what their options are and how to access those options. As mentioned in the introduction, my work is mostly in the community. I do a lot of work with community engaged research, qualitative research, and basically hearing the voices from the community and gathering narratives from women who have experienced breast cancer to understand their lived experiences a little bit better in order for us to connect them with care in a better way. So I wanted to start today with just a quote from one of the ladies that I met during my work in the community to show you how the disparities that Black women or how Black women experience breast cancer is slightly different than other women. This particular woman said, "I have worked really hard to make sure my boys are not caught up in what's happening out there. You know what I mean? They are in school and doing well. If I'm too sick to keep up with them, who else will? I just don't know." This particular participant and survivor, care was delayed for this person up for a year before she actually started treatment for her breast cancer. I spend a lot of my time, my work is in the area of health disparities, and I just wanted to review. Many of you who are on this webinar understand what disparities are, but I just wanted to review the definition for those who may not. Health disparities are differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. How does this display itself among African Americans? This just shows you a few different disease categories where health disparities are very obvious between African Americans and white Americans. For example, African Americans are 2.1 times as likely to die from asthma, 40% more likely to die from stroke, 30% more likely to have heart disease, 40% more likely to be obese, and we can go on. But we're going to talk about cancer today, and breast cancer in particular. So with breast cancer, as mentioned earlier, even though the incidence or the rate that women are diagnosed with breast cancer is equal between white women and Black women, the death rate, African American women have a 42% greater chance of dying from their breast tumor than white women. And my research looks at where you live makes a difference. So you can see here that if you were in Chicago, an African American woman would have a 48% higher chance. In Los Angeles, a 71% higher chance. In Houston, a 51% higher chance. So my research looks at more than just what we would typically think of when we think about disparities and we think about what's happening and what the lived experience of Black women may be. A lot of times people ask, well, is it an issue of insurance? Yes, but we do have some answers for that. Access to care, transportation, yes, but we also have some answers for that. Trust in the healthcare system, definitely. Fear, yes, it does come into play. But there are other factors that come into play that are less studied, but yet they have a major influence on delay in care for African American women. And many of the women that I interviewed for my research, care was delayed as much as 2 years before they were able to start treatment for a variety of reasons. Some of those reasons here, I've outlined 4 just for today in essence of time. And I'm going to show you an example of each of these: chronic traumatic events, pride, social isolation, and demystifying the treatment process, and their influence over late-stage diagnoses and treatment initiation. So the first one, a quote I want to read is a woman who, when I say the word pride, I just mean that women have spent a lot of time to build safety and stability for their homes. They have worked really hard to make sure that their families are healthy, their kids are stable, they have housing security, food security, and yet sometimes when they're in the patient-provider relationship, they don't always feel that those things are respected. And this is just one example. This lady said, I thought it might have been stress and all that I had to deal with on a daily basis. I knew it was something, but I never thought it was cancer. They wanted to know from me, how could you take a bath every day and not notice that you had tumors protruding through your skin? I said, my kids are fed and clean every day. I get them to school on time. My house is clean. I take care of my grandmother and I work full time. I was able to pay my bills and take care of my kids. By the time I got in the bathroom to take a bath, it would be 10 o'clock. I would jump in, shower, and literally almost pass out being so tired because I worked full time. So I didn't pay any attention to my own health because I was responsible for 4 other people. In this situation, she just really wanted her provider to understand that there were so many other factors at play in her life that coming in to look at her, to take care of her own health, was sort of down the list of priorities. Social isolation. I look at socially isolated communities, meaning that these are communities where it's hard to get information in about, what is available, what insurance is available, or how can I pay for medications if I am diagnosed? Are there social workers or other people that can help me with my kids if I am sick, or someone that can come into the house and help me if I'm sick? A lot of times people don't even know that these resources are available to them. In addition, almost all the women I talked to for my study kept it private. They didn't tell anyone. They didn't tell their adult children. They didn't tell their church friends. They didn't tell, their neighborhood friends. And so I just have a couple quotes here. I told no one. I told my parents I was having a procedure and asked if the kids could stay with them for a few weeks. It was summer break and they were out of school, but I didn't tell them it was cancer. Another woman said, some people are embarrassed and ashamed and scared of what might happen if they get treatment and don't want nobody to know, because I did. Your self-worth is gone. I really felt like that. I really did. Another woman said they hide it. They act worse with the cancer than gonorrhea. They think it's taboo to have it. And then finally, this idea of a lot of times when I'm presenting around the country, people will say that, are people afraid of having cancer, of being diagnosed with cancer? The women that I talked to weren't afraid of being diagnosed with cancer. They were concerned about what the effects of treatment would be on their quality of life. This woman said, I think that once they are diagnosed, they need to rush to get them hooked up with someone who has been through it. If you have someone that is going through it, maybe making treatment decisions, and you are looking at a survivor like me, and I tell them what I went through and everything is going to be all right, they would trust and believe that person. I think they would be more susceptible to going ahead and getting it done and going on through the treatment process. Some people don't want to. Cancer is going to change your life, and some people don't want to change. So what do we do about this? How can we help Black women who are going through, who are survivors of breast cancer, connect with care in a more timely fashion? First, we need to have more community-based programs that start with messages of, it's okay to talk about it, using women of color to share their experiences with treatment with other women of color. I hear that a lot. People want to hear from people from their community who have experienced this. And sometimes they don't want to go to a support group downtown at the cancer center, but they want to hear from people in their own community. A focus on demystifying the process of treatment itself, like helping women understand to some degree what they may or may not experience once they start care. Not that we can tell them specifically what they would go through, because everybody experiences treatment in different ways, but at least having the conversation. Increasing communication between clinical settings and community-based agencies to increase the availability of resources so people know what's available to them. And then creating academic and community partnerships to address community access to supportive care, such as food deserts, mental health services, complementary services, safety. I mean, if we tell people to go for a walk and their walking paths aren't safe, then they're not going to go for a walk. So we have to partner with communities in order to address more systemic differences and disparities. And then increasing communication between clinical settings and community-based agencies to demystify the clinical trial process in order to get more African Americans in clinical trials so that we can have treatments that are more tailored towards African American tumors. In order to know what African American women need, we need more African Americans in clinical trials, but there is a lot of confusion around that. So with that, I'm just going to say thank you, and I appreciate you allowing me to speak with you today, and I will turn it back over to Tia.
Great. Thank you, Dr. Noel. I know we have some great questions for you, so I'm glad you can stick around to answer them for us later. Now we're ready to welcome our second panelist this evening. You may recognize her from the recorded session that we sent out to you. She is one of the hosts of the Three Black Docs podcast. Zanetta Lamar Md is a native of Louisiana and is a triple board certified in internal medicine, hematology, and oncology. Dr. Lamar is an author of more than 20 scientific publications, reviews, and a book chapter. She has been a principal and co-investigator of several cancer-related clinical trials. She is a mentor, educator, and has a passion for improving patient care. Welcome, Dr. Lamar.
Thank you so much for having me. I am so excited to be here. And Dr. Noel, thank you for that fantastic presentation. I really enjoyed it. And to everyone that's participating, thank you for being here. So my name is Zanetta Lamar, and I am a community oncologist in Naples, Florida. And my goal today is to give you practical advice on how to advocate for your care. Dr. Noel told us a lot of the reasons why there are disparities in care. And what I want to give you is advice on what to do when you go into the doctor's office tomorrow. Okay, so I have five things that I want to talk about. And by the end of this short presentation, you will know all 5 of them. Okay, so let me go ahead and get started. The very first thing that I want to talk to you about is list it. List it. What in the world do I mean by that? Every time you go to the doctor's office, from henceforth, now and forevermore, I want you to walk in with a list of questions or comments. If you are new and you have been newly diagnosed with breast cancer, you really, really want to sit down before that appointment and come up with a list of questions. Some of those examples of some of the questions that you may ask are, what stage am I? What does my pathology report say? Who will be on my treatment team? Who are the people that I will come in contact with? When you go into a doctor's office, there are many people that you come in contact with, and it can be incredibly overwhelming, particularly if you're newly diagnosed. If you've been living with breast cancer for some time, I still want you to have a list of questions every single time you step foot in that office. And so, while this really helps with physician-patient communication, the other thing that it does is it shifts the power differential. So when I walk into a patient's room, I actually am walking in and I'm coming from a source of power, right? I'm wearing the white coat, I'm looking doctorly, I sit in a big chair that has the wheels on it, and you are sitting in a smaller chair, right? There is a power differential when you are in the clinic. And one of the things that happens when you come in prepared and ready to ask questions is that it helps to equalize that power differential a little bit. And it makes your healthcare provider, answer those questions, and it lets them know how engaged you are in the process, okay? And so you always want to make a list. Now you may say, I don't know what questions to come up with. Well, actually, there are some books that are available, particularly if you're newly diagnosed. There's a website called Educare, and we can maybe talk about that a little bit more later on. But there are books that can even give you questions about what to ask that very first time you go into the clinic. And so from henceforth, now and forevermore, every time you step foot in a doctor's office, you will come in with a list of questions. Now, When you ask that list of questions, I want you to try to do it as early as possible during that clinic visit. You don't want to wait until the doctor has their hand on the doorknob and 1 foot out the door. You want to do it early on in the visit to make sure you get the very most out of the visit. So step 1, list it. That brings me to step 2. Doc, how are we going to fix it? Okay, so you want to talk with your physician about what the next steps are. Henceforth, now and forevermore, when you go to the doctor's office, you will not leave said doctor's office without knowing what the plan is. What are my next steps? You know, sometimes it may be a mammogram, an MRI, it may be a referral to a different specialist, but I don't ever want you to leave without knowing what the next steps are. And one way to make sure you know what's going on next is, you know, once it seems like that clinic visit, and clinic, that just means the same thing as the doctor's office. But once that clinic visit is almost over, I want you to say, hey, do you mind summarizing what we talked about just to make sure we're on the same page and I understand everything that you said to me? Okay, so step 1, list it. Step 2, doc, how are we going to fix it? Now, that brings me to step 3, and I call this your healthcare bill of rights. What in the world do I mean by that? So, you know, I know sometimes when you walk into the clinic, you may sign a form that says your patient bill of rights. This is a little bit different. This is my version. So it is my fundamental belief that you have a right to be treated well. You have a right for your body to be respected, okay? Unfortunately, in America, that right to health care comes with a bill. And I can assure you, before you walk out of that clinic visit, a bill will be generated and headed towards your mailbox. So I call this your healthcare bill of rights. And so what in the world does this mean? This means that I want you to know the financial team within your physician's office. There is always a group of people, or maybe sometimes it's a person who helps to navigate the financial journey. In our office, we call them financial counselors. And financial counselors are critical to your care. I want you to meet with them early. I want you to meet with them often. Honestly, in the best case scenario, I want you all to be on a first name basis, because what financial counselors do is that, one, they can help you with expectations of the cost of your care. You want to know who's paying for what. They can help you with things like, you know what, how much is my deductible? How much will I have to pay? When does my deductible change each year? And also, if you've had significant changes in your insurance status or in your employment status, you want to let those financial counselors know as soon as possible. The other thing is, often the financial counselors know where the money is stored. So if there are community programs, sometimes they're the best people to reach out to locally. They can also help you with national programs that may be able to help you with your care. And if you cannot afford something that a physician or someone on the healthcare team has recommended for you, I need you to shout from the hills and say, you know what, I'm not sure I can afford it. Because what that does is it prompts us to go ahead and get that process started to help you to try to find resources. But if you don't say anything, then we won't know. And if there are resources available for you, you want to know them early. Okay, now, step 1, list it. I want you to make a list. Let's help change that power differential in the clinic. Step 2, doc, how are we going to fix it? Henceforth, now and forevermore, you will not leave a doctor's office without knowing what the plan is. You want a summary. Summarize this plan for me, the treatment plan. Step 3, know your healthcare bill of rights. Healthcare, I believe, is a right. In America, it comes with a bill in that mail, okay? So know your financial team. Meet with them early and meet with them often, okay? So that brings me to step 4. And step 4 is, I really want you to have a cancer advocate or a cancer companion. You know, in Dr. Noel's talk, she really highlighted the impact of social isolation. Okay, I need you to have someone that knows what's going on with you, someone whose name and phone number you are willing to put in your medical chart, so that if something happens to you, or if we need to contact you for some reason, we know, oh, you know what? This person has a healthcare advocate. We can call them, and they can make sure that information is communicated. Cancer, it's breast cancer particularly, it's such a difficult journey. And I don't want you to be on this journey alone. I really want you to sit and think, is there a person that I can designate to help me, that I can talk to? It may be a family member, it may be a spouse, it may even be a coworker, but do not, do not walk this journey alone. Okay? Now, you may say, well, I'm a cancer companion. The reason why I am listening to this broadcast right now is because someone that I care about deeply right now has breast cancer. Okay, thank you for joining us. As a cancer companion, really your job is to help them navigate that journey. You know, you may be the person that helps them with their list of questions, that helps them, um, to make sure they understand what's going on with the clinic visit. But also, you can be very helpful in delegating, um, and helping them through that. So you may say, what kinds of things can I do with delegating? Because you may love someone who is an independent person and likes to do as many things on their own. So what are some things that you can do to help? One, meal trains. Sometimes when you're going through cancer, particularly if you're going through cancer treatments, you may not feel like cooking a meal. So setting up a meal train can be important. Helping to babysit the kids. You know what? Cleaning up the kitchen. If they let you clean up the kitchen and you know how to clean up a kitchen to their standards, that's something that you can do. Mowing the grass. But whatever you do, you want to do something that helps to decrease the stress. Dr. Noel just taught us about social isolation and what can happen with social isolation. So we don't want you to be isolated. We want you to have someone who is on this journey with you that you can trust. Now, you may say, you know what? I'm actually socially isolated. I don't have anyone in my life that I trust. And you know what? That's what Living Beyond Breast Cancer is all about. This is a community of people who know exactly what you're going through. Many have walked this journey. And so, reaching out to your online community can be helpful. Okay, but henceforth, now and forevermore, I do not want you to keep this to yourself. Please, please, please let someone know. And also, just with having another person's name in the chart, it's incredibly important. I'll tell you, this happened to me today at work. I need to have someone to be able to contact. And really, you want someone, and we feel more comfortable as a healthcare team if it's someone that we've met before, that has been a part of the journey with you. So think about designating a cancer companion. Okay, now let's go through these steps again. Step 1, list it. You're going to make a list. Step 2, doc, how are we going to fix it? You want a summary of the plan before you leave the doctor's office. Step 3, know your healthcare bill of rights. Become friends with the financial team in the clinic. Step 4, have a cancer advocate or companion. And if there's no one beside you to walk, reach out to your online community just like you're doing right now. Now, that brings me to step 5, and this is an incredibly important step. I need you to take time to restore your soul. Sometimes after, the word cancer has been attached to your name, you are fundamentally changed. And sometimes there's so much going on after a diagnosis of cancer. There's mammograms and biopsies, and sometimes you may have scans, you may have blood work. You're meeting all these new people. You're trying to navigate, going to different clinics and trying to make this work, while you're working. And so there are so many things that are happening. And actually, Dr. Noel gave an example of there's so much going on, but you don't take the time to restore your soul. And it's incredibly important. So this weekend, I want you to sit down for 15 minutes to an hour, and I want you to think about the things that are meaningful to you. What are some of the ways that you can restore yourself spiritually? Whether it's kind of listening to an online spiritual broadcast or reaching back out to your church or community organization. I want you to do something to nurture your soul spiritually, emotionally. If you haven't yet and you feel like you need to, I want you to take the time to grieve. This is a process, and especially in the Black community, we wear an invisible cape so much that you never really take the time to process what you've been going through. And today, I give you permission to release the emotions that maybe you haven't been able to do. So take the time to restore yourself emotionally. Also mentally, 2020 has been a year like no other. And COVID and everything else that's going on in 2020, it doesn't care that, you have cancer. And so that just increases the stress. And so if you feel like you are reaching your breaking point, I want you to let somebody know. And, one thing that has been helpful in the COVID era is that now there are more online therapists and psychologists and people that can help you. And if you feel like you are on the verge or you're really struggling, I really want you to reach out, because there are people who care about you. The reason why this conference was even formed is because we want to end disparities in Black people with breast cancer. So there's a community of people that you don't even know that care about you so much. And so if you do nothing else, I want you to take some time and restore your soul. Martin Luther King said, of all the forms of inequality, injustice in health is the most shocking and inhuman. And I can't wait until there's a day where I don't have to give you a talk on advocating for yourself, because people like me in healthcare, we advocate for you. And there's no difference in care. I can't wait for the day when the word disparity doesn't exist. Right now it does. And so until then, I hope that you can use these points and that they're helpful to you. But really, the last thing that I want you to know is that you may have cancer, but please remember that cancer does not have you. Thank you so much for your time, and I look forward to the question and answer period.
That was awesome. Thank you so much, Dr. Lamar. Dr. Noel, we'd like to bring you back on and jump into our Q&A.
Thanks, Tia.
Awesome. We have a lot of great questions, and I want to thank everyone for posting their questions in the Q&A section. If you have any additional questions, feel free to continue to post them in the Q&A section. I'll go ahead and get started. So we have a question from Rhonda. How do you recommend overcoming distrust of the medical system as well as other obstacles of navigating treatment in order to participate in clinical trials?
I think that for me, at least, the key to that is working within communities and partnering with community leaders and people within the community that already have trust. Because we can't go into communities and just dictate what communities need and to tell them what they need to do. That's not gonna work. But if we can work within the community to find out what the needs are and partner with those communities to then address what the questions are, I think that builds trust over time. And also, it's a long-standing relationship. It's not like run in, run out. But we need to make sure communities understand that we care about them and we're here to stay and we want to be a part of the community and not just, come in and take care of one prevention method and then leave. So I think that helps to build trust over time.
Yeah, I mean, I agree with Dr. Noel. Only about 2 to 3% of physicians are Black. And so really, more than likely, the physician that you have may not be a physician of color. And so I think one way to help with distrust in the community is exactly what we're doing right now. Because if you go in to a clinic visit and you are informed and empowered, I like when people walk in with expectations, right? You know that I deserve to be treated, right? So when you're diagnosed with cancer, you're already, it's a vulnerable situation, right? So you feel very vulnerable, and sometimes there can be a loss of control. And so what knowledge does is that it empowers you and it gives you that sense of control back. And so while, we may not be able to be in every community, we can find a community. And so that's why I'm so excited about this conference, because you know what? Most people can get online. And so if you know, hey, this is what I should expect from this visit, and your expectations are not met, then you feel comfortable to say, you know what? I'm not feeling this relationship, doc. I'm going to have to go somewhere else. Because, I mean, sometimes in the community, even within my family, having people get a second opinion, there are some people who don't want to do it because you're like, oh, I'll just deal with it. No, once you're empowered and once you have that information, your expectations are different. And so I think that helps with trust because you know what to expect. And so, over time, I think that we will be able to, hopefully, we'll have more physicians who understand what's going on. But until that day comes, we're just going to keep teaching and putting out information as much as we can. Great question.
Great. There still seems to be a lot of stigma associated with talking about breast cancer, in particular in the church. I've been told that women were advised that they shouldn't talk about such private matters as breast cancer in the church. This adds the burden, the shame, and misinformation that exists in our community. How can we go about addressing this? All right.
Okay, let's talk about the church. And let me give you my background, okay? I am the daughter of the son of a preacher man. So I come from a line of preachers. So look, I read the Bible for the first time when I was 6. Come at me about church. And the thing is that, if we can learn that faith, and it works with science, right? Faith works with science. And so sometimes what I've seen in church, and it's been so disappointing to me, is that people feel like if they are not, if they don't have the joy of the Lord all the time, or, if they are not healed, that somehow their faith is not what it should be. And I'm coming right here today to shut it down. The reason why churches are there is to help the sick. That's the whole mission. And so we really have to change the stigma within our churches. And really, if we can do that, and it's really by letting people know what's going on, because I think there are just some people who may not understand, and sometimes you don't want people in your business, but really churches are powerful communities. And so I really hope that, moving forward, if you're hurting, that's okay. Really, that's what churches should be for. And we have to change. We have to change it. There are lots of churches who are trying to change that, but faith and science, they really work hand in hand.
Yeah, so we talk about, the church. which is very interesting. And this brings us to our next question. When we look at older family members, we don't tend to talk about it. We may have a family history of breast cancer, but we don't have the conversation. You know, nobody wants to talk about our grandma or our auntie that passed away. We'll say that, you know, they just passed, but we don't talk about what actually happened. So we don't have enough information, and that harms us when it comes to our family history. So how can we address this issue? How can we break this barrier down culturally within our families?
Mm-hmm. And I can say that I'm, you know, in my research and the women that I've interviewed in the community, I heard that over and over again. There's a story that I can share where a young lady who I was interviewing said that she was going through radiation and she burned really bad and she was suffering, and she had to go to like a family reunion meeting with some family, her cousins, because they were planning. And when she got to the meeting, 4 of her cousins at the meeting said, "Oh, I went through that. Let me give you some advice. This is what you need to ask your doctor the next time you go. This is what I used." And they had no idea that 5 of them were breast cancer survivors. And so, and they just never talked about it. It was just not something they talked about. And I think that it kind of, you know, I don't know how we break that cycle. Maybe Dr. Lamar can speak to it. I don't know how we break that cycle, but I do know that I hear that a lot from the community.
Well, you know, one of the reasons why it's so important to break the cycle is because now we're doing genetic testing. There are drugs that sometimes we can use in people who have certain genetic mutations. And so it's not just, you know, knowing what happened. This is impactful for your care, because if you tell me certain things, so many people had breast cancer at a certain age, and you know, it will change. And so then you know what to tell your children to prepare for. So I really think one of the best ways to get family history is through, you know, is honestly during the family reunion. I mean, now on your, you know, as you're handing out the family reunion t-shirts, we need to say, hey, you know what medical problems do we have? Let's get a running list and keep it. Like my family, we have a family Facebook page because we couldn't have our family reunion this year because of COVID. But I mean, you really have to know, it's so important, not only for breast cancer, but I'm going to put a plug in for prostate cancer as well, because we're doing genetic testing in prostate cancer and it affects Black men, and they need to be tested earlier. So, you know, this is really important. And so, you know, I think before we really didn't have much to do about it, right? So it's like, you know, such and such had breast cancer, but then you just know, but it really didn't change, you know, your next step. This is changing the next step, and it's changing how you're being screened. So it's incredibly important to start talking about it.
So speaking of talking about it and genetics, what do we do when we have a situation where we think our daughters are at risk? How do we handle that? What should we do? And I'll throw that one to you, Dr. Lamar.
Good question. You know, you talk to your oncologist, because sometimes what I'll do during the clinic visit, I'll say, hey, you know, because of this, you want to tell your children X, Y, or Z. And, you know, your daughter may want to get screened earlier, or may want to get an MRI instead of a mammogram at a younger age. You know, there are certain things that we do differently. So really, I think the best way is to work through the network that you already have. Okay?
Great. Now, let's turn this a little bit. We talk about care and getting the appropriate care. How do we handle a situation when we really don't feel like we're getting the appropriate care that we need? Or how can we fire our oncologists? How do we deal with those situations?
Good question. Good question. So, Dr. Noel, did you want to jump in? Or okay.
Actually, punting that.
You're punting. So how do you fire your oncologist? So I really think of this journey as a relationship. Okay, this really is a relationship. As an oncologist, we get attached to our patients. We want to know, you know, there are things I want to know about my patients, and it's a relationship. But honestly, it doesn't work for everyone. Okay. And so if you don't feel comfortable in getting the care that you deserve, then you can go to another clinic. And you can also sometimes see another physician within that same network. This happens more often than you would realize. And so really, you're not hurting your physician's feelings. And if you are, honestly, you probably need to fire them anyway, because really they should want the best for you. And if you all are not communicating in such a way that it benefits you, then you really want to go to someone who can. So I want you to know that, you know, there's probably not a physician in America that has not been fired if they've been practicing for any length of time. Okay, so it would not be the first time, nor would it probably be the last time. And so, you know, if you're not getting the information that you feel like you deserve or in the way that you deserve, remember, you're paying money. You are paying me to see you. So if you don't like your service at a restaurant, you don't go to that restaurant anymore. So you're paying very good money, and you need to get what you deserve. Bottom line.
So I'll throw this next question over to Dr. Noel. And I think this is a great one, kind of piggybacking off of what we were talking about with Dr. Lamar. As a Black woman, sometimes, you know, people may see us as aggressive or see us as overly emotional. So how do we clearly communicate our concerns with our provider without showing, you know, so that it doesn't come across as though we're hostile or we're being told to calm down? How do we communicate this? And we don't want to, you know, seem as though we're undermining their credentials. So Dr. Noel, help us out here.
That is a great question.
That's good.
That is a really good question. First of all, I'm going to answer that, I think, in two different ways. First, I don't think there's anything wrong with being emotional when you have been told you have cancer. I think that is a reasonable response. But that being said, to answer your question, I think it goes back to what Dr. Lamar was saying about being prepared and being able to, you know, jot down your questions, take somebody with you, have a champion with you. And that helps you. If you are, like, my mom just went through chemotherapy, breast cancer, chemotherapy, radiation, and I went with her, her sisters went with her. Somebody was always there for that exchange with the doc. And I think that helped with her, you know, keeping her calm so she could ask the questions she wanted to ask, and keeping us calm so we could ask the questions we wanted to ask. And so I think having someone there with you helps that. I think being like the list that Dr. Lamar gave earlier of, you know, trying to list your questions ahead of time so that you're prepared when you go in, as prepared as you can be,
right, will
help as well. But I also I really believe it's okay for you to be emotional. I mean, this is a turning point in your life and I think that providers have a responsibility to meet you where you're at and not expect you to be somewhere else.
Great answer. Great, great, great. So when we think about, you know, all the things that you all are talking about, you know, we're looking for resources. Everyone's needing some resources. Where can they go to find good resources? And also, how can they find a Black doctor or Black support groups? Dr. Lamar?
Yeah, I was going to say, do you want to take that?
So, you know, actually, I think, you know, this is a very nice forum. And there are, you know, Black cancer networks online. Honestly, probably some of your best resources for Black specific information is online. I do know that, you know, they've been trying to get a list of, you know, Black doctors in different areas across the country. Sometimes, I'll be honest with you, that can be hit or miss, especially in the Black oncology community. I mean, our numbers are low. I mean, we're 2 to 3%. So sometimes it's just where you are and asking people within your communities. That's where support groups locally are so important. But Living Beyond Breast Cancer has some fantastic resources on their website. And I think, honestly, this is a good place to start.
Mhm.
Yeah, and
Agreed.
I will just throw in, since we're talking about, one of the questions that came up was about finding the support groups. I mean, right
Mm-hmm.
here, just in the chat alone, we have a nice group of, or a large group of Black women and men
Right.
who've been diagnosed with breast cancer. So feel free to post in the chat, let them know that you're looking, and I'm sure that people can share that with you. And also on social media, there's so many groups that have been formed of Black women and breast cancer. So definitely share
Right.
and come to our fall conference. We will have a chat for Black women and men, and that you can connect with others who are just like you, who've gone through the journey. So my next question, let's talk about metastatic breast cancer in the Black community. You know, it's, how do we deal with this? How do we address the fears? How do we address just the issues around metastatic breast cancer that people are not talking about?
So a lot of times when, someone says, they have stage 4 or metastatic breast cancer, it's, I mean, people, they're crying, you're hugging, it's, no, I fully expect people to, to live with breast cancer. Some of our treatments have changed substantially over time. And so, um, I have expectations for you to thrive while you're getting this treatment. And so, I mean, really, it's getting the information and knowing, the most about what you're going through. And so that's one of the reasons why when you're talking with your physician, I do think it's important to keep the physician honest, right? So as an oncologist, we are naturally optimistic. Okay, and so we are doing the best for our patients, but um, you know what to expect on your journey. I'll be honest with you. I call it my oncology lifetime, I've seen so many changes in breast cancer, particularly in metastatic breast cancer. And now, you know, there are more clinical trials and there are more things available for people who have metastatic breast cancer. So, you know what? That's why, I said at the end of my talk, you may have cancer, but cancer does not have you. And so I think that, it is a journey, and you're going to walk through it. You're going to have a community, and we're gonna walk this journey. So I don't want you to think that just because this is metastatic breast cancer that this is it. No. Mm-mm. Mm-mm.
We have some folks from our Facebook Live chiming in. So can you speak to the side effects when it comes to Black patients, in particularly tamoxifen and Taxol? How do we address this issue in our community?
Yes. So, so tamoxifen is a pill that's taken every day, and it's used for people who have estrogen receptor positive breast cancer or something else called ductal carcinoma in situ, DCIS. And it can impact estrogen levels. And so, one of the things about these drugs is that if there is a drug that for some reason you cannot tolerate, there are other options. So, don't just think that, oh, you know what, the doctor gave me this drug and I'm just going to have to push through, and I'm going to have to. No, like if you're having issues, just say, you know what, I'm having issues with this drug and I don't think I can tolerate it. And so I can't tell you how many conversations I have a week navigating side effects from, tamoxifen and other pills that people are taking. And that's where you really individualize your care. Now, with Taxol is an IV chemotherapy. And sometimes you can have what we call reactions. And so what we do is we really try to give you medications ahead of time to try to minimize those reactions. And then there are some people who just can't tolerate the drug at all, right? And we may have to change it. That's why it's so important to let us know what's going on. Because if I don't know, then there's a problem. I had a patient tell me last week, oh, you know what? When I was getting this drug last week, I started getting hives and I felt like my heart was racing and I didn't know if I was having difficulty breathing, but, I just let it pass. And I said, what? You didn't tell us what was going on? Are you kidding me right now? Like, so communicate with your healthcare team because we really want to minimize side effects. It doesn't benefit me or you for you to be suffering endlessly through treatment. So we really want to try to mitigate those as much as we can.
So what do you do when you tell your doctor you're in pain, you're experiencing these side effects, and they really don't do much for you? I remember when I was actually going through treatment, it took my doctor 4 weeks to get me over to pain management to address the pain. So what do we do when they don't respond?
Good question. So let's talk about pain because you see, you're gonna get me passionate again. And I was trying not to show emotion because I didn't want to make them think I was aggressive. Look, when you have pain, here's the problem. Here's the problem, Lord help us. So there is good data to say that a lot of people do not believe Black people who are in pain. I didn't make this up, okay? So if you are in pain, actually one thing that you can do is to do it on, say what, you know what? My pain was a 10 out of 10. I felt like I was getting hit by a Mack truck. How would you feel if you were getting hit by a Mack truck? What would you do for yourself? And so sometimes as physicians, if they're not believing you with the pain, I want you to put it on a number scale, okay? Everything's not going to be a 10, right? So 10 is the worst pain you've ever had. Think of having a baby without anesthesia while you're, doing something else crazy and have a broken leg, right? So that's a 10 pain. A 0 is no pain at all. So that's why it's important when I say you go to the doctor's office with a list. Number 1 would be pain. And so you would say, look, I am having pain. It is an 8 out of 10. What are we going to do about it? And then if you feel like it's not being addressed, okay, let's get back to this pain. What are we going to do about it? Okay, so if pain is one of those things where we already know the data says that people won't believe you in pain, that you have the pain that you say that you are. So really, really, really make them hear you with your side effects. Okay.
So, Dr. Noel, I'm going to pass the question over to you.
Okay.
So when we think about what we're going through, and there's a lot of emotional stress and trauma that we deal with behind this disease, how do we deal with the daily fear of a cancer recurrence? How do we address that?
That's a really good question as well. I think that, obviously the support groups we're talking about, the online support, having champions in your life and having other people who have gone through, who you can talk to, who you feel safe to talk to is helpful. I would also say there's no shame in seeking a social worker or clinical support, if counseling support, if that would help in a more private setting. But I just go back to, don't deal with that in isolation, because it's a normal fear. It's a normal process. And if you talk to others, if you can find others in the community who have gone through this, they will probably tell you that they've been feeling the same way, and you can find an ally. So I would go back to what we were saying earlier about, don't deal with this in isolation. Please talk to someone. Please let someone know that you're feeling this way. And then talk to your provider. Let your physician also talk to them. Tell them if what are can we talk about reoccurrence? And maybe that would help. I don't know, Dr. Lamar, if you agree with that, but knowledge is power. Knowledge is empowering. And I would say, ask your provider, find a support system, and don't keep it to yourself, but definitely share that either in counseling or with a support group of friends.
Yeah, you're right. Knowledge is power. That's why we've titled this series Knowledge is Power, because we really want to empower people to really get the information that they need so they can get the care that they need. So speaking of care that they need, we think about clinical trials. This is like the big one that we are all challenged with. With the level of mistrust in the community, how do we engage more Black women or African Americans in clinical trials?
Yeah, I'm going to go first only because you're probably going to have a better answer, Dr. Lamar. But this is what I still believe that it goes back to knowledge, right? And understanding of what clinical trials are, how they are helpful. And I know that there's a lot of fear and a lot of mistrust about being used as guinea pigs in trials. And some of that fear is, I don't know, relevant in the sense there's chronic diseases and other things that are happening. But at the same time, I think some of it is just people just don't know the benefits of clinical trials, and therefore we don't have enough African Americans participating. And I'm just going to say one thing, and I'm not a physician. I'm just going to say that I think that when I'm researching and I'm working with communities and I'm researching different, when I'm looking through articles, almost every research project I look at has like an African American, African American participation is less than like 10%. And if it remains like that, all of the treatments we're developing are going to be based on a majority white population and majority, and so therefore we don't know if that's applicable to our population and our tumor types. But I'm going to turn it over to the physician because obviously I'm not a doctor and she can correct me.
No, I 100% agree with you. And so I also think that this is a twofold problem. One, when the clinical trials are being written, we're not in the room. And I tell you, I have been a part of, and I'm speaking to the sponsors of this conference. Do you hear me? You are not making clinical trials in such a way that Black people would, can really participate. Your eligibility criteria is too stringent. This is a disgrace. It has got to stop, because when I use these drugs in the clinic, I am using these drugs based on patients that I am not treating. So this is it's unconscionable that we are still doing this in 2020. And so really it has to start when those clinical trials are being written. We have to kind of liberalize some of the eligibility criteria. I've seen some clinical trials where if your blood pressure is 140, is higher than 140/90, you can't be in the clinical trial. Are you kidding me right now? Like this is crazy. And we're using these drugs on people. So I'm sorry, that's a whole nother talk. The other thing is that I also lay blame at the hand of the physician, because we are not always offering these clinical trials. And so in advocating for yourself, I was going to add like a clinical trial piece, but when you're going and you have that list of questions, one of the things that you may want to write down is there a clinical trial available for me? Okay, so then it's unfortunately putting the onus on the patient to do the job that the physician is supposed to do. But I agree with you. I mean, these drugs are not studied in Black people. The thing that's interesting to me, and I've done a lot of trials and participated, is that I've never had trouble accruing Black people to clinical trials. It hasn't been difficult. So, I sit down and we say, hey, this is what's going on. And there's something as a physician that we have called clinical equipoise, right? I don't force you into clinical trials. I say, hey, you know what? This is what we would do standardly. this is, you know, what we have available. I'll tell you kind of pros and cons of each approach, and let's talk about it. But I've never had trouble recruiting. So I don't think that our community is as distrustful. I think the information is not being presented, or it's not being presented in a way that anyone understands. And I lay blame at the hand of the researchers who are, you know, making it difficult with their eligibility criteria. So, I mean, this is a problem that can be solved. It can be solved.
So let's say they find a clinical trial that is suitable for them.
Mm-hmm.
What are some things that they should actually consider before they actually participate in a clinical trial? So what are some things that they should,
Sure.
both the patient and the family should consider before being a subject of the clinical
So one
trial?
of the first things is that I want you to know what phase the clinical trial is. And phase, P-H-A-S-E, what phase? So, you know, basically with a phase 1 clinical trial, what we're trying to do is, honestly, we are trying to find the correct dose of a new medication. That's the goal of a phase 1 clinical trial. With a phase 2 clinical trial, we are trying to find out, is this medication, does it work, right? With a phase 3 clinical trial, we are comparing that new drug to the current standard that they're using right now. We know in a phase 3 clinical trial, we know the drug works, but is it better than what we're already doing? So when you're researching a clinical trial, you want to say, hey, you know, what phase is the clinical trial, right? And so that you have a clear understanding of what to expect. Because what I've seen, and this is wrong, I've seen some people say, you know what, I have this phase 1 clinical trial and it's going to work and we're going to, you know, that's not the goal. The goal of a phase 1 clinical trial is to try to find that correct dose. And so I think you really need to be honest at the forefront with knowing what's going on. So one of the first things that you want to do is, what phase is the clinical trial? Then you also want to know next, hey, is this a trial that is maybe just at your particular cancer center, or is this a trial that's open all across the United States? Okay. And so, and also, when you are learning about a clinical trial, there is always a research nurse or someone from the research team that's available. And so really that person is at your disposal. It's actually one of the things that we like in people who are on clinical trials. You actually have another set of hands. You have more people on the team to help to take care of you. And so they really are also available to you to help you understand what's going on. And really, you want to feel comfortable. One of the reasons why you know, I want people to understand is the reason we have the treatments that we have now is because of the people before you who participated in clinical trials, right? So everything that we're doing now is a product of the clinical trial generation before us. Okay, so I mean, I'm so grateful to the brave women who participated in many breast cancer trials, right? Especially some of the surgical ones years ago. Because of what they did, we know that you can do things like breast conserving therapy, right? But I mean, these were, you know, brave women. And so really, not only are you with a clinical trial, you are really, really honestly helping the generation after you, right? So, you know, they really are important.
Yes. So let's talk about COVID. So since COVID has been here, it has restricted so many people from actually being present at the doctor's office and the treatment centers. What suggestions do you have for advocates to be able to just stay connected to the cancer community and support these women and men who are in treatment?
I actually think that online networks, again, I think one of the, if there could be any benefits from COVID at all, is that we are connected online now. We're connecting with support groups and with our families, and more people are learning how to use Zoom and other media to connect with people, which is connecting people across barriers that they would not have otherwise been able to connect with in the past. You know, you can connect, I'm in Austin, I can connect with someone in Houston, I can connect with someone in Detroit. And so I think that helps a little bit. I think that, though, it's still difficult to, you know, to navigate these waters when there's so many other things happening in and around us. But I do think this is an opportunity. This has been helpful a little bit to have online connections.
Mm-hmm. And I will say, you know, even in my clinic here in Florida, we're still not letting, you know, visitors in the clinic area. So one of the things that I've done to help navigate that is, you know, when a patient is on my panel, we ask ahead of time, you know, they want such and such called, or, you know, they will be doing FaceTime and a spouse or a child will be on the line as well. So really, I really like when advocates are involved. So as you have your list, when that doctor walks in the room, I want you to say, hey, I'm going to call such and such. Okay? Don't wait till the end of the visit to say, oh, do you mind if we call my son? And I'm like, well, where was your son the whole time? We could have called him. So really at the beginning of the visit, you want to have your advocate involved. And honestly, if you're with a physician that's not willing to do that, just go ahead and fire them. I mean, just go ahead and fire them. And also, I'll be honest with you, this week alone, there were some things that I wanted, you know, spouses to be involved. And so I've gone out to the parking lot, call it my parking lot ministry. So, you know, just to go out to them while they're in their cars so that you really understand and we can see each other face to face in a socially distanced way. So we've done all kinds of creative things. Today, I did a conference phone call, you know, with two family members who wanted to be involved in the conversation. So, I mean, we really are trying our best to be creative. So people should still be able to be involved, even if they're not physically sitting in the room.
Now, when we think about our patients, what are some beliefs that you hear from new patients that, you know, they want to know more information and, you know, they have all of these beliefs, but they're not really sure what's the right information and maybe what's the correct information, what's not correct or incorrect information?
All right. So I'll take that. Dr. Noel and I are looking at each other.
No, we were both like,
we don't want to jump into it. No comment. So I'll tell you. So, you know, there is a rise of misinformation. Mm-hmm. And I'll be honest with you, each year it's getting worse and worse. And I have seen people who have done poorly, honestly, because of misinformation. And it's one of the saddest things that I see. One thing that I think generally when it relates to your health, honestly, you know, sometimes moderation is good, right? You want to exercise, you want to eat healthy, but you don't want to go too far into extremes. And also, I would be very, very careful with doing supplements, particularly during chemotherapy. We need to know exactly what you are ingesting in your body because we know side effects associated with chemotherapy. But sometimes we're like, well, where in the world is this coming from? And you find out after the fact that maybe they were taking 30 supplements. Okay, so if you are taking supplements or something else, you got to be honest about what you're doing. Don't be open and honest about everything that's going on so that we know how to prepare for it. And also, you know, I'll be honest, you know, I think healthcare has done itself a disservice. And I think that's why there is sometimes a rise of misinformation because I don't think as a whole, sometimes we haven't treated people the best. And so you're searching for other things and you're searching for something that seems truthful. And honestly, you know, a lot of things, they just don't have the data that we do. And so we really don't know what will happen to you with this particular thing. So just be careful. There is a lot of bad information out there, and and also be careful. You know, I also said have your community, but be careful with your community, because sometimes when you say you have cancer, people will start sending you, you know, blueberry pills that you need to take 5 times a day. So just there are no lies. There are no lies. So, you know, just be careful in what you're saying, and just be open and honest about the things that you're doing. Because, you know, with some supplements, sometimes what happens is, you know, I'll have a patient give me supplements, and we'll kind of check off what's good and what's not. Okay.
So speaking of vitamins and
Uh-oh.
healthy living,
Uh-oh.
you know I'm coming at you with this one. So
Dr.
what
Noel?
diet suggestions would you have for someone who's actually going through treatment that they should be doing? Maybe if there is some kind of regimen that you would recommend. So that's for people who are going through treatment, but those who have completed treatment, what are some recommendations that you would have for them also to be preventative of a recurrence through
That is
lifestyle?
an MD question.
Oh, did you say that was an MD question? Oh, I thought you said, oh, I have this question.
No,
I was like,
I said that's an MD
okay.
question right
So
there.
here's what we know. We do know that limiting alcohol use, being active, staying healthy, exercising 2 hours a week, all of that helps to it helps to improve and helps to decrease risk of cancer recurrence. And so, but by the same token, sometimes after you've had chemotherapy, it's hard for weight and things to drop. And I actually see a lot more kind of mental stress with the focus on the weight. And I want you to focus on the activity. Okay? So instead of focusing on the weight, I want you to focus on the activity. Are you getting in at least 2 hours a week? Okay? Just know that, look, my insides are good. My insides are good. But that chemo is making it hard to drop these pounds, but you know what? My insides are good. And so, and also eating more vegetables than meat. Okay. These are, you know, sometimes easy ways, but I'll be honest with you, sometimes it can be difficult. And even, you know, for people who are on endocrine therapy, some of the pills that you have to take, sometimes it can be difficult to lose the weight. So I don't want you to feel guilty. What I want you to do is try your best and to take baby steps. Okay?
So Dr. Lamar,
Uh-oh.
you just told everyone to stop drinking those wine glasses that they've been drinking.
I said limit. I said limit. Well, can we? Well, you know, I can talk about everything. I was like, I know. And then y'all watching 3 Black Docs, right?
Right. You know, we love our wine, right? What about sugar? You know, there's that big thing everybody knows about sugar or has been saying about sugar. Can you speak to that?
Yes,
sugar
yes, Lord. I hear about sugar all the time. So now here's the thing. Now here's the truth of it all. Your body actually needs sugar to live, right? You need sugar to be the building blocks for you to have energy. The problem is that there are so many things that are enriched with extra sugar. Okay, and so you really want to be careful about the foods that you eat. And so that's why, you know, I try to preach moderation. There are some people who are already, I mean, they had a 100% healthy diet before they went on this breast cancer journey. I think it's really, really hard. Some people may disagree with me, but I think it's really hard to have lots of significant changes at the same time. Okay. And so I actually prefer that you take baby steps. Okay. So, you know, we can't eat fried foods and eat 10 bags of potato chips every day. It's just not good for you. And so that's why I actually like to try to focus on first trying to eat more vegetables than meat. Okay, if you can tolerate it. Now, I've also had some people who eliminate sugar completely from their diet, even things like fruits. I mean, fruits are good for you. Fruits are, you know, have healthy sugars in them. And that can be dangerous. I mean, it's almost impossible to eliminate all sugars. So you know, you want to do things in moderation. I tried to answer that as best I could. We could go
Oh
on
no,
about this all day.
That was really
that was
good.
great. That was great. Thank you. So I know we have so many more questions and we don't have a whole lot of time, but I'm just going to wrap up with this last question, or I'll tie two in together. One is around cannabis. So what are your thoughts around cannabis, using cannabis? And then what are your thoughts about palliative care? How do we address palliative care for cancer patients when they hear that word and there's some fears that may be there?
Yeah.
And I'll start with Dr. Noel. Maybe you could answer that about the
So I don't
fear
have
in
an
palliative
answer.
care.
I was going to say, I don't have an answer for cannabis.
Right.
But yeah, fear and palliative care for sure. Yeah, I'm actually a really, this is a very special area for me too, because I'm a big advocate about more people utilizing end of life care. But I think people define it differently. They when they see it, they think that life is over. When a lot of times, palliative care helps the family process what's happening together, and to be able to come together and heal together and communicate, and to palliative care is just really good at helping with what's going to happen. They know, and they can help the family. And not enough people take advantage of that. But being a community-based researcher, I just go back to the fact of knowledge. And again, knowledge is power, and educating communities on what it is and what it isn't, and trying to get more people to understand it. Dr. Lamar probably has a way better answer for that, but I do think it's super important though, Tia.
All right, so I'll start with the cannabis. So there are different forms, right? And so, you know, the thing that I will usually say is I don't like for people to smoke it during chemo. Okay, just because, you know, if blood counts drop or something happens, that just makes me nervous. So there are different forms that you can use. And I'm like, look, I'm your doctor, I'm not your preacher. You know, you do what you have to do. There are different forms, and it has been very helpful. Different forms with nausea. Sometimes it can help with anxiety. And so I am not anti-cannabis. Okay, I just like to know how you're using it, and so we can talk about, you know, maybe some of the best times, and you know what. I just want to know what you're doing. Okay, I don't necessarily want you ingesting a whole lot either. You know, I just don't like things happening during my chemo that I don't know about. Okay, but so I think that there is a role for some people. When it comes to palliative care, palliative care just means to palliate, right? To kind of help make feel better, Ugh. So, you know, there are different reasons to use palliative care. Sometimes it's in the treatment of pain, right? Maybe your pain is such that I don't feel like I'm doing a good job controlling your pain, and I may send you to a palliative care physician to help. One of the things that I think is really important, you know, there's palliative care and there's also hospice care. And sometimes, you know, palliative care, you may be in palliative care and sometimes there's a transition to hospice, sometimes you're in palliative care, and that's it. I think that this is a journey. And one of the terrible things that I think that has happened with discussions around cancer is that we term cancer as a battle, as if it's a war. And anytime, you know, we're always like, oh, you know, there's a battle with cancer and you're battling. And I really dislike that terminology because it makes it seem like there are winners and there are losers. You know, we never say, oh, you know what, such and such lost their battle with stroke, right? We don't say that. And so I think it makes it seems like there are winners and there are losers. And no, this is a journey. And so I think that's why it's important to know when you're talking to the doctor, and I had that second step, doc, how are we going to fix it? You know, it's like, what's the treatment plan? What happens if this doesn't work? What happens if this doesn't work? And so then you know, like, hey, these are the steps so that nothing comes as a surprise and you can be prepared. So I think that really everything goes hand in hand if presented in the right way. And I think it's so much better to be prepared. This is not a battle. This is not winner and losers. This is a journey.
Wow, we've had a lot of great discussions tonight, and there's so many more questions that are coming through, and we don't have enough time. I wish we did, but I want to thank everyone for joining. We've talked about community, we've talked about self-advocacy, we've talked about self-care. We've had a lot of great discussions tonight, and I just want to thank both Dr. Lamar and Dr. Noel for joining us. Thinking of you and looking forward to seeing you again.